My name is Mike Grovitz. I'm a spine surgeon from Nottingham. Pleased to introduce my co-moderator, Dermot Ferguson here. We're running a few minutes late, so we'll proceed without delay. Just on an admin point, have we got a Mr. or Dr. Sunny here? Okay, no, it's okay. That makes it easier because he or she has not submitted their talk, so we've only got 6 talks here. So without further ado, can I introduce Matthew Bellamy from Sheffield, talking about adherence and factors related to completion of SRS 22 PROM forms. Thanks very much, Matt.
Good morning, ladies and gentlemen. Thank you very much for having me today. I'm delighted to share my research with you today, titled The Adherence and Factors Related to the Completion of SRS 22 PROM scores in Patients Undergoing Surgical Correction for AIS. I've got no disclosures for this research study. So you're probably thinking, not another talk about PROMs, come here for paediatric spinal deformity, but just one thing to bear in mind while we go through this talk is that SRS 22 is very important. Now, 3 key reasons I've identified is that we can gauge the operative success in the short and long term, we can quantify and find patient satisfaction levels in measurable ways, and we can also track the trends in time to show how our surgeries are evolving. Now, we took our SRS 22 questionnaire from Sheffield, and what we wanted to gauge was what was our level of completion, but we also wanted to take it a bit further than that. And we wanted to identify variables like phone number and email address, and also the deprivation levels of patients to see does it impact on our levels of completion. Now, why do mobile phone number and email address actually matter to the clinician? Well, as this infographic shows us, there's 2 routes of entry of data into the BSR. One of these routes of entry is the manual entry, where patients fill in questionnaires with pen and paper, and the other is by the automated route, where email address and phone number send out reminders for patients to complete their questionnaires. Now, we took 207 patients from our surgical practice from 2018 to 2022, and we identified their British Spine Registry records. Now, we wanted 4 key variables from the British Spine Registry, which included preoperative, post-operative 6-month, 1-year and 2-year questionnaires. We wanted the level of email availability, the level of their phone number availability, and also their postcode, so we could work out what their deprivation levels were. And now, what did we find? Well, we can see in 2018 we had about 62% completion of all valid SRS 22 questionnaires, but you see the sharp declining trend over the past 5 years, and at 2022 we're under 40%. Now, this you can see also a plateau between 2020 and 2022. Now, if you break it down even further, what we find is that the preoperative and postoperative questionnaires are the highest, but still quite low, at roughly about 58%. And this declines all the way to 1-year and 2-year, where we're finding we're not even averaging 40%. Now, it's also worth mentioning here that the 6-month time point here is the lowest, and this is the only nurse-led telephone checkup. Now, I mention this because the other 4 are consultant-led clinic visits, which could imply that there's some psychology behind when patients fill in the questionnaires. Now, if we look at mobile phone number and email availability, we actually find that our mobile number and email address are quite good, averaging about 85%. Now, the graph on the bottom left-hand corner there shows that actually we are having a declining level of contact information even in a new digital age. Now, you'd think for patients who have an email address, a phone number, or an email address and a phone number present, our completion should be quite good because we can get in contact with these patients. But even in patients with one of these available, we're still missing over half of their data. So we wanted to take this a bit further, and we wanted to predict patients who we think would have good long-term follow-up using the variables we'd identified. Now, what this model showed us was that having a preoperative or a postoperative, preoperative and a postoperative present made the 6-month nearly 4.7 and 3.5 times more likely, respectively. If you then completed the 6-month questionnaire, your 1 year was nearly 6 times more likely to happen. And then if you had the 1 year present, the 2 years was nearly 10 times more likely. We also found, interestingly, that having a phone number present, having an email address, or the level of deprivation of these patients had no association, for good or for worse, on the levels of completion of these checkpoints. So what are the key messages I think are important to take away from this talk? Well, SRS 22 completion rates are falling, and this falls in line with the recent reports published by the BSR. Early engagement predicts that long-term adherence, and getting that pre- and post-operative questionnaire makes sure and enables us to have long-term completion from these patients. Without these pre-operative and post-operative questionnaires, it's unlikely we're going to get any long-term follow-up. Now, from increasing engagement with the BSR, the potential research opportunities grow. However, we need good completion before this can start. Thank you very much for listening, and I'm happy to take any questions, and my contact details are there for anyone who wishes to get in contact after the talk.
Yes, because of time constraints, what I've made of... Sorry, Steve, you're here. Just, is that Steve? Yeah. One question, please. Yeah.
So Steve Morris from Bristol, thanks very much for that. I think it's important to be collecting this so we know that we're doing the correct thing. Because a lot of these patients are going to be children, do you collect their parents' email addresses and phone numbers? And do you think that's a factor in whether people are actually going to complete it? Because the parents may be getting a lot of emails from other work-related COVID things.
Yeah, I think most definitely. I think in the AS population, some of these children are just coming into sort of the age where they're probably getting a phone number or an email address, and actually what we're collecting is their parents' phone number and email address. And what we probably have to do is make this a joint effort between the kids and the parents. I think especially in the younger kids, this has to be seen as almost something that's imperative to their care, and the parents need to know this as well. This is not just a checklist that they complete, they get the surgery, and then they leave for 2 years. This is part of their follow-up care, and I think it's important we make both of them aware of that.
Thank you.
Matt, just given the 30% at 2 years,
yes.
Is there a significant chance of bias in interpreting those 2-year results compared to the immediate post-operative ones? And do you have a feeling as to sources of those potential bias in terms of, you indicated, perhaps socioeconomic deprivation, and their attitudes therefore feeds into their, if you like, appreciation of the results of surgery?
I think most definitely, and I think as sort of alluded to in the point before, patients are willing to get the SRS2 completed at the pre- and post-operative surgery mark because they're keen to get on with surgery, and they're wanting to almost show that they're engaged with the process. But 2 years down the mark, they've probably almost forgotten about it, and they're busy living their lives. And it is probably very skewed because the patients who probably may be filling out the questionnaires are actually the results that we want, because those are the ones that maybe have the problems later on down the line.
Thank you very much. Very quickly, please. One more question.
Actually, one last question.
Yes.
I don't think anybody's assessed the personality traits in the questionnaires any time to be able to assess whether these guys are going to actually fill in the questionnaires or ignore it, or is that literature still not happened yet?
I'm unsure of any literature assessing personality traits, but I'm more than happy to collaborate on that idea if you think
great
it's
ideas. Yes, have a chat over coffee. So thank you very much, Matt. Thank you very much. Great paper. Do we have Dr. Mariscal here? So yes, welcome. The paper is Efficacy and Safety of the Use of Perioperative Gabapentin in Patients with Adolescent Idiopathic Scoliosis Undergoing Fusion Surgery, a Systemic Review and Meta-Analysis. Thank you very much.
Hello everyone, my name is Gonzalo Mariscal, an orthopedic surgery resident at La Fe Hospital of Valencia in Spain, and thank you very much for the scientific committee for accepting this work. We have nothing to disclose. So gabapentin acts on central sensitization, and multimodal control of pain is gaining importance. Liu et al. Showed that gabapentin decrease postoperative pain and morphine consumption, but in non-spinal procedures. Our objective was first to assess whether the preoperative use of gabapentin is associated with a decrease in opioid consumption, and then to assess the side effects. We follow the PRISMA guidelines and BICOS strategy. We compare the gabapentin in intervention group to the standard preoperative medication. So here we are going to have heterogeneity among studies. Some of the exclusion criteria, here we can see, and we just include randomized controlled trials. This is the search strategy regarding the data extraction. We extract some baseline data, and the primary outcome was opioid consumption. We made subgroups, and secondary outcomes, some adverse events like transition time until oral medication, length of hospital stay, and period of urinary catheterization. We assess the risk of bias by review manager. We follow the Cochrane recommendations for the statistical analysis, and we use the wet plot digitizer and review manager softwares. We also did additional analysis to assess heterogeneity, like sensitivity and funnel plots. The first search yielded 24 studies, but with the exclusion criteria, we include 4 randomized clinical trials. The risk of bias showed that the studies had a high to moderate risk of bias. This is the treatment strategies, very heterogeneity, but the important thing is that we include 200 patients, almost 200 patients. The mean age was adolescent. It's adolescent idiopathic scoliosis, and of course, most of the patients were females. 2 studies include preoperative gabapentin and 2 perioperative. Regarding the main outcome, there was a significantly decrease in opioid consumption during the first 2 days in favor of gabapentin group. When we divided by doses, the 15 milligrams per kilo showed a superiority in reducing opioid consumption during these first 2 days. No significant differences were found regarding the time to introduction of oral medication, length of hospital stay, and urinary catheterization. There were no publication bias assessed by final plots, and when we made the recommendations by the grade system, the certainty of this recommendation, these results were moderate. We have several limitations. Of course, the number of included studies were small, so that limited us to do subgroups or meta-regression. The final results were influenced by the study with the highest weight, that is the sensitivity analysis. These studies were very drug-focused, and of course we have to consider the heterogeneity in different treatment schemes. So in conclusion, this is the first meta-analysis on this topic, and with a moderate degree of certainty, we can conclude that gabapentin in this kind of patients, after undergoing fusion surgery, decreased opioid consumption during the first 48 hours. And doses of 15 milligrams per kilo show with superiority in reducing opioid consumption. We get an accepted a few weeks ago in the European Spine Journal, and I would like to thank Omedics for the statistical analysis. Thank you very much.
Yes, please.
Hi, Fadi Sedra, Royal London. Any change in the in-hospital inpatient stay? Did it make any difference in terms of inpatient? Were there one of the criteria that we looked at here?
Yes, here is there were no differences.
There were no differences.
Hospitalization time is the second.
Thank you.
No differences, but two small numbers.
Thank you very much for that study. Did you notice any problems with gabapentin? When we've used it, we've had problems with monitoring?
Yeah, when this is a meta-analysis, so we just took information of the literature. This is not our data, and we could not compare adverse events in terms of, for example, diseaseness or, this kind of adverse events, because the studies did not report in a way that could be compared. But if we analyze individually, these kind of effects were very small. But doctors should be aware that in patients, because this is idiopathic scoliosis, but in older patients, for example, they should consider addiction, or in this kind of patients to make a reduction, progressive reduction, or not to give gabapentin. But this is adolescent idiopathic scoliosis, and is not probably that kind of patient among them.
Gonzalo, having done the exercise you have now and concluded that there's moderate evidence, what do you suggest that we can do to strengthen the evidence for the use of gabapentin for those people in the audience that are not convinced of the current evidence?
Yes, I think future studies should report outcomes in an homogeneous way. I think this is the best point, because if not, we cannot compare in the way of the high level of evidence, meta-analysis, and report not selecting outcomes, because if we see the risk of bias analysis, the selective reporting was a high risk of bias. So we need to report to give outcomes about the efficacy, the functionality of the patients, and then adverse events, and divided by doses, and to try to homogenize a scheme of treatment, because it's very heterogeneous, as I say, what medications we should give postoperatively, or,
Thank you very much, Gonzalo. Thank you very much. Have we got Jessica Robinson?
I'm not Jessica, but
Okay, yes. Welcome. Thanks, Rav. So in lieu of Jessica, we have Rav. Diagnosed too late, proportion of adolescent idiopathic scoliosis curves that are added to the surgical waiting list at first presentation to a pediatric spinal clinic. Thank you very much.
thank you very much, Mr. Gravitt. I'm hoping the key point of this message is that we've demonstrated a single centre service evaluation should be translated to a multi-centre evaluation to get a real picture of what's happening in the UK. So potential delays in diagnosis from when a curve starts to appear could be between the curve developing and someone at home or at work or at school recognising this. It could be a delay in then seeking their GP appointment, or it could be between referral and being seen in clinic. There's a big spectrum there. And depending on where those delays occur, it could be that things happen in a really timely way and we catch them at a point where bracing is an option. Or it could stretch out that we see them in clinic at this point and the only option remaining, potentially, is surgery. And we've missed the boat for bracing these patients. So we wanted to find out in our centre, of all the patients added to our waiting list in a year's period, how many of those were presenting at their first clinic with a curve which was over the surgical threshold? Did the pandemic have an effect on what we were seeing in our clinics? And did social deprivation, was it associated with a delayed diagnosis? So we looked at two cohorts, all of our waiting list additions in 2019 and all of those listed in 2022, pre and post-COVID. And in this period of time, in 2019 we had 107 patients, in 22 we had 109 patients. And of these, 42 were AIS patients and 47, so relatively comparable pre and post-pandemic. If we look at how many of those were listed at their first clinic, or at least from their first clinic and within 3 months with no further x-rays, we had 56% in 2019 and 63%. Fairly comparable, but actually quite a large proportion. And if you look at their mean cob angle, it was broadly in the low 60s. So we started then looking at, actually, are there patients with a large cob angle presenting to clinic, but actually they want to delay the decision to go into surgery? So we just looked at everyone added to the waiting list in those years who actually presented with a curve over 50 degrees. And this was a staggering number. We had 73% added to our waiting list who always were never having the option of a conservative management with bracing. This was high, and we felt that this didn't change pre and post-COVID, but was not acceptable. So we started wondering, was this our fault? Were we not getting to them quick enough after a GP referral? So we looked at our times, and they were relatively acceptable. I appreciate there was a difference pre and post-COVID, and it was a bit of a longer wait post-COVID. But in the grand scheme of our waiting list from referral to being seen, not extremely long. So not our fault, thankfully. So then we thought, is it happening early along in this journey? Is there something to do with social deprivation, which means that they're presenting later with larger curves? And we looked at index of multiple deprivation, both their score, their rank, and some individual domains, health, disability, and education and skills. And looking at all of those domains, it didn't show any association between their rank score and whether they presented with a large curve. If you drill down into it, there were a couple of analyses which were statistically significant, but I'd take these with a pinch of salt, and this is because it's only a single centre study. So I think the key points are, we are, in our centre, getting a patient presenting to the clinic with very large curves, quite late, and they are missing the opportunity to have conservative management. It wasn't due to the COVID, that didn't make an effect. Our outpatient waiting time was not long, and it wasn't linked to social deprivation. But this was a single centre study. We should find out what our national picture is like, and if the audience feel that this is a sensible step forward, I propose that we try and find where our delays are occurring. And if we can find that out, maybe we can develop some interventions in the long run. Is it that we need to go back to a screening system, which I'm sure will raise eyebrows for a lot of our colleagues? Do we just need to increase awareness? Do our GP colleagues need education providing to make sure that there's no further delays? Or actually are some of our centres having a very long delay from referral to being seen? Thank you very much.
Please.
Hi, Neil Davidson from Liverpool all day. Good talk. Congratulations on getting your patients in being seen within 60 days. That's incredible. We can't do that. The question I've got is, did you look at the type of curve that was presenting and the age of the patient? Because my feeling is that the younger patients tend to present earlier because they tend to be the kids running around with their tops off, and so they get spotted earlier. And then perhaps the type of curve, some curves are more noticeable than others.
We didn't look at type of curve, and I think that's a sensible thing that we should consider building into the scaled-up version of this. I don't think the numbers that we were looking at 2 single years, would be able to answer that question. But we did look at age, and certainly there wasn't any correlation between their age and the size of the curve that we were seeing. So age, no, but potentially curve type and how that cosmetically appears may have a factor, and that's a really sensible thing that we could build into a national project. Thank you very much.
Rob, just to follow on from Neil's point then, I like the fact that one of your icons, you've got someone swimming. And certainly on a sort of personal level, I always noted that the number of referrals I got sort of had jumped up after the summer holidays when the girls first put on their sort of bikinis and they went on holiday. Did you notice any seasonal variation in the rates of referrals from GPs?
We didn't break down by month, but anecdotally we see a similar thing. And actually that was very much the reason why we looked at social deprivation, as there's clear kind of links between going on holidays, what extracurricular activities kids are involved with, in social deprivation. So that is already known, which is why we looked at that. But we didn't look at seasonal variation. Again, could be considered, but I think there'll be a lot of confounders with delay from referral to being seen. And you'd almost have to accommodate for that to work out whether that seasonal variation is true or actually being lost in the delay between being referred or identified and referred.
Yeah. And just on that social deprivation index, do you think there's a reasonable chance that this is a sort of type 2 phenomena, in the sense that, that a lot of the kids that are picked up, in the summer holidays, etc., that implies that the parents can A, afford to go on holidays, and B, they're really engaged and have close association with the kids in after-school activities, etc. Do you think there's a risk of a type 2 error here?
I think that's entirely possible. We didn't see that, and I think a large study may be able to see if there is an association there, but we're always going to be at that risk of a confounder.
Yeah. Sorry, please.
Okay, just a quick one. Do we know how quickly curves progress from 0 to 50, sort of that period before? Has there ever been a study done where they've actually looked at, how quickly a curve would progress? Just out of interest.
I'm not sure I could quote the literature for that. I mean, that would be a holy grail piece of work to know at what point what certain curve types become cosmetically visible. If anyone knows from the audience that, please jump in. But to my knowledge, I don't.
Alex, good morning.
I don't know the answer to that either, but I've got another question, which is, a surgical hit rate of 70% sounds perfect to me in the private sector. But I think you're talking a little bit cross purposes. You labelled it as delay in presentation, but I would say it's late presentation, because you haven't demonstrated any delays in the process once it's been noted. So the only question really for you to look at is whether screening, we should maybe have another look at school screening. And but that brings a whole load of other problems and other harms into the equation.
Yeah, if we have a trial that can show that bracing is effective and it's not destructive and damaging, that might bring back a screening program. If only we had a trial that was recruiting.
So if there are no further questions, I'd like to thank you very much, Rav, for stepping in and some interesting questions. Right, the next paper is great pleasure to welcome Zach Silk from Oxford. Reducing blood transfusions in pediatric scoliosis surgery, the impact of an MDT-based approach. Thanks very much, Zach.
Thank you, and thanks for the introduction, and I'm really grateful to be able to present this data on behalf of Mr. Lucas and the team at Evelina Children's Hospital. So, as many of you know, blood loss in pediatric scoliosis can be extremely substantial, and there's historically high rates of blood transfusion associated with this and all the attendant risks to children that are well documented. However, over the past 2 decades, there have been significant advances in blood conservation strategies, and with this in mind, the team at Evelina Children's Hospital have sought to implement an MDT evidence-based quality improvement project that's been running for over 15 years now. The aim of this presentation is really to evaluate the efficacy of this program and also to provide really fundamentally a contemporary benchmark that perhaps some of you may find useful to take back and look at your own data. But many of these interventions you'll already have in practice, and they've been iterative. I mean, essentially, sequential improvements over time as new techniques and knowledge have been produced. So in terms of the study design, I mean, this was fundamentally a retrospective review of prospectively collected data. It included a 20-year period, and almost 2,000 procedures were included within this database, but a number of exclusions were applied, and fundamentally this dealt with fusion operations on children or children who progressed to early adulthood with scoliosis, and that culminated in almost 1,500 patients having surgery. The main outcomes of this presentation really is to look at transfusion rates and volumes, and also an association with length of stay, which is being presented for the first time at today's meeting, although this data has been presented by colleagues at previous meetings earlier on in this process. So just in terms of context, many of this won't surprise you. Average age and female to male ratio is very similar to what you'd expect, as is the choice of approach. Almost 70% of the patients were considered type 1. I'm sorry for the colour difference, but type 1 patients in this study were categorised as AIS patients over the age of 10, and everybody else, neuromuscular syndromics and early onset patients, were categorised as type 2. So if we just look at the overall transfusion rates over the last 20 years, the cohort as a whole, it was 8.8% for the AIS patients and 44% for the type 2. But really, what I do think is of value is just looking at the trends over time. So the top line is represents the type 2 patients, so the neuromuscular syndromics and early onset patients, and the adolescent idiopathics are in orange. And, you know, fundamentally, there is a gradual trend towards reduced transfusion from nearly 100% back when the service started in 2001 to less than 1% in the most recent analysis for type 1 patients, and less than 20% in neuromuscular patients. And these are some of the inflection points, you know, when cell salvage was introduced back in 2003, and also the integrated care pathway fundamentally, which came in 2006. But also we can see other iterations, so NICE guidelines. I don't have the details of some of the other introductions, such as the use of tranexamic acid, but essentially this does show a cumulative improvement with an iterative quality improvement approach. We also saw a similar reduction not only in transfusion rates, but also the volume of blood being provided to patients, and this was also very much in line with NICE guidelines, which which state that hemoglobin should be checked after each individual unit that's given. But what has been of interest recently has been its association. So this is not causation, but it's association with length of stay. So there will be a number of confounders, including enhanced recovery programs and greater patient education and staff education here, but fundamentally there was a downward trend in length of stay over this time period. And when we compared the non-transfused to the transfused, so looking at type 1 in orange, as before, there was a 2-day additional length of stay if they were transfused, and this was similarly seen in the type 2 cohort as well, so from 6 days to 8 days, I think reinforcing the importance of applying these principles of blood conservation in practice. So in conclusion, this study provides a benchmark transfusion target of less than 1% in type 1 patients and less than 20% in neuromusculars and syndromics. And fundamentally, this could lead to a reduced length of stay over time. And really, I just want to end on this quote just to reinforce the importance of quality improvement projects. And again, I want to thank Jonathan Lucas for giving me the opportunity to present this on behalf of the team there. Thank you.
Alex, please.
Zach, I know it's not your service, but just a couple of comments. A transfusion rate of 100% in your first years of doing the surgery should have led to that serious questions being asked, in my view. That's a bit much.
No, understood. I mean, I have to say, going back through the data, if we look at the recent years, I mean, they're averaging between 150 to 160 scoliosis operations per year. In the early phase of the when they were ramping up, it was sort of less than 5 cases a year. So
that brings me to my next point, really, which is, do you think it's your MDT and your iterative process and all the different measures you've put in, or do you think it's just the way that your service has matured, your surgeons have got better, your anaesthetists are more trained at getting hypotensive anaesthesia? Because I think it's probably the latter. I don't think it's got anything to do with your MDTs, because all you can do is keep the blood pressure low, give them tranexamic acid, and use cell saver. That's all you can do, isn't it?
Well, yeah, you can, and preoperatively as well. I think just screening out patients who have low hemoglobin, heavy periods, and optimizing them with iron is I mean, it's been shown in this data.
Okay, so don't operate on anemic patients. Brilliant.
But I would challenge, I mean, Alex, I would challenge you and anyone else. I mean, would you be able to quote your own transfusion rates for AIS and non-AIS patients?
No, I've got no idea, but we don't often transfuse the type 1 patients at all. But every case is so different, isn't it? If you're doing an AIS case that's T4 to T12, I mean, the transfusion and complication rate from that is practically zero. Right? But if you're doing an AIS type 1 case from T2 to L4 or L5, that's a completely different case. So I think it's more important the specifics of the case that you're doing and the surgical tactics, rather than just saying that, aren't we good, we've managed to reduce our blood transfusion rate over the 20 years that we've been doing scoliosis surgery, because you're 20 years better.
Raja, just one question.
Yeah, hi. Thanks, Zach. What was your transfusion trigger? Do you have a agreed transfusion trigger?
Yeah, the transfusion trigger evolved over time. So at one point it was 80 grams per deciliter, and in the most recent iteration of the program, it reduced down to 70, and that's in line with NICE guidelines. I mean, NICE guidelines were in place back in 2015, and they made recommendations for children over the age of 1 for a transfusion trigger of 70.
You know,
it's taken years to see that happen in practice.
Just for brevity, I'm just going to interrupt you. So the reason I am asking the transfusion trigger is because our paper that we published from Manchester in 2008, the single important factor that reduced our transfusion rate was your transfusion trigger. And the second thing is that your transfusion trigger has to be measured at 48 hours, because that is where the trough of the hemoglobin is, which is similar to what happens in hip and knee replacement surgery. Thank you.
Okay, so in the interest of time, we will press on, because we have Dr. Sunny in the room. Yes, okay, so we will try and get you in. So without further ado, please, can I welcome Dr. Ravine, talking on development of the brace adherence prediction questionnaire based on protection motivation theory.
Thank you. So the key point in this paper is actually the methodological approach that we might want to take away and apply if we are developing prediction tools or new prompts, which plenty of people are screaming out for. Now, with brace adherence being the key factor in treatment success, it'd be ideal if we could predict that at the time of diagnosis. And a few papers have tried to do this, but they've all been relatively flawed. There's been no underlying validated theory that underpins it. Sometimes patients were not even involved in the development of these tools. They've been poorly validated with retrospective, subjective adherence. And for that reason, that they haven't really taken off, and we don't really know how good they are. So I'm hopefully going to solve that problem with the BAPQ. And the methodology we used to achieve this, or to develop it to this point, is we identified a theoretical framework which was going to underpin the work. We used semi-structured interviews, which are dyadic, so with patients and parents involved in the interview. An item generation process, which was then reduced with expert panel as well as PPI involvement. And then we're going to be prospectively validating that, but that's coming soon. The underpinning theory was protection motivation. This goes back to the 1940s, where you use a threat appraisal, how worried you are about scoliosis and needing surgery, versus the coping appraisal, the things you need to give up to be able to be adherent to treatment. And that is what informs your intention to behave or comply. So if you're interested in the qualitative work, there's a poster and also the video from BSS last year, poster number 10, so if you're interested in the qual work, come see me. But from that work, we extracted out 8 key themes which straddled the 7 domains of protection motivation theory, and here they are. From this, you can generate a lot of items across all the domains, and we started with a long list of 90 potential questions. And much like some of the other questionnaires previously, very much a scattergun approach, and then figured out which of those questions were predictive. But we went for a slightly more targeted approach and rationalized this first to 38 questions, which we felt that straddled the constructs of protection motivation theory, but wasn't labor intensive. And we put those 38 questions to our expert panel and PPI group in a cyclical fashion to change wording, change constructs, to get to the final questionnaire, which is 32 questions. This 32 question BAPQ is now being validated through the BASIS study. This questionnaire has been delivered pre-randomization, so they've had their first appointment with their consultant, they know their diagnosis, and whatever information you tell a patient at their first appointment. So at that point, they are naive to what treatment they're going to receive, and they've never worn a brace, so they have no idea what their experience is going to be like. We then repeat the questionnaire 6 months down the line. And the beauty of validating this questionnaire through a trial is that we have prospective, objective adherence data using the thermal sensors which are embedded in all the BASIS braces. And then many years down the line from the trial, we'll know actually clinical outcome. So this questionnaire has the potential to be even predictive of what their clinical outcome is going to be, potentially. So the BAPQ has 4 key USP selling points. It's underpinned by protection motivation theory, which is a theory which has been operationalized to predict adherence, but never in kids naive to treatment for a treatment period which could be potentially 4.5 years. So it is taking on a big challenge. We use dyadic interviews, so both patients, parents were involved, and a key involvement of our stakeholders. So that was 7 surgeons, 3 orthotists, 5 specialist nurses, and an extended scope physiotherapist. We're going to be prospectively validating it, and we're using objective adherence data. So I think the take-home message is, if you're going away and thinking we need to develop some other prompts for things you're interested in, find an underpinning theory, think about who your stakeholders are and how patients can be involved, and parents if they're pediatric, and think how can we best validate this questionnaire. This potentially can allow really rigorous item reduction to get this down to potentially 8 questions, which are truly predictive. If you're interested in using the questionnaire in your own work, please contact me. There's a QR code there. Thank you very much.
Very good. Any questions at all? Rav, I may have missed it in previous presentations, but what's the internal consistency like of these 32 questions? In other words, you know, if you submit it to a Cronbach alpha analysis, what is the, because it's quite a lot of questions, if I may say so, you know, and
Yep.
you know, given what I suspect is quite a broad range of Cronbach alphas, do you really need all of them to achieve those ultimate long-term goals?
Yeah, I would hope with the adherence data, what we'll do is we'll reverse engineer and be able to distill out which questions are predictive and to what indexation each question should have on each of the 5-point Likert scales. So at that point, we probably can reduce from 32 to a small number.
Yeah.
Can I guess what that is? I'd love to target something like 12, but that will be only dictated by the maths and the adherence data that we have.
Yeah.
So it'll be truly mathematically sound. And the nature of having a large trial to run this through is once we do item reduction, that can happen in the next couple of years, and actually the remaining half of the basis patients will probably fill in BAPQ 12.
Yeah.
And we'll really understand which ones are predictive to what amount. So that's the hope.
Yeah, and things like the test and retest reliability, given the demographic we're considering, is that something that is potentially an opportunity? Because, you know...
Yeah, so we're doing test retest, but not with the basis patients, so we're not overloading them with questionnaire fatigue. But we're doing the test retest with same cohort patients, but not within the trial. The pre and post brace treatment questionnaire, that 6 months, is what's probably quite interesting to see how their interpretation of their vulnerability and severity changes actually after they start a treatment. Or you've had 2 appointments with your surgeon and they've drip-fed you a bit more information about actually your curve is likely to progress, or actually you've got a very good chance of avoiding surgery. So you'll find out with that interval having been repeated over 6 months.
Thank you very much, Daniel.
Thank you very much.
Thank you. So the next paper is a systemic review and meta-analysis. Does anterior-posterior spinal fusion still have a role in severe thoracic AIS surgeries? So Dr. Lassia, thank you very much. Welcome.
Very good day to one and all. I'm very pleased to present this research work comparing anterior-posterior spinal fusion and posterior spinal fusion in severe thoracic scoliosis. We will cover the topic under the following headings. There's always been a surgical dilemma if anterior release is warranted before doing a posterior spinal fusion. The optimal indication was considered to be large, stiffer thoracic curves where we would do thoracic discectomies prior to doing a posterior spinal fusion with the hope of achieving a better curve correction, fusing lesser segments posteriorly, and also decreasing the incidence of crankshaft phenomenon. The posterior spinal fusion, often done by pedicle screw instrumentation, is evolved massively to the point that we can now do segmental derotations, and these, along with the posterior osteotomies, can actually preclude the necessity of an anterior release altogether. These are the advantages and disadvantages of anterior release, the most important ones being decreased fused segments and decreased incidence of crankshafting. These are some of the cases managed in our center with anterior-posterior spinal fusion, which shows excellent correction of the curves. The aim of the project was to compare the APSF and the PSF based on the following variables: Cobb angle, complication rate, pulmonary function, number of fused segments, and the prompts. We identified 680 studied after abstract screening and full text screening. We narrowed it down to 8 studies which met our inclusion criteria, the most important being a Cobb angle of more than 70 degrees. We then did a quality assessment based on grade approach and minus criteria. Grade approach enumerated by Schoenman et al., where the studies were classified into very low, low, moderate, and high grade evidence. Most of our studies fell in moderate to low level evidence. Minors criteria was used to assess the risk of bias. The perfect score on minors criteria should be 22 for comparative studies, and we identified that none of those 8 studies actually met the perfect score, which meant that they were all inherently biased. We used the following models for statistical analysis. Coming to the results, looking at the Cobb angle, as you can see on the forest plot here, there was a trend towards anterior-posterior spinal fusion. However, this did not reach statistical significance. The complication rates were noted more in APSF group, hence favoring PSF, again, did not reach statistical significance. The number of fuse levels were found to be fewer in one of the studies in the APSF group without being significant. The pulmonary functions were reported in 2 studies. One was better in APSF, one was better in PSF. And the PROMs were identified in 3 studies, reported in 3 studies with no differences reported between the groups. There was another meta-analysis which was done by Chen et al. In 2016, which compared similarly APSF and PSF. They proved that PSF was actually slightly better, if not equal to the APSF with respect to curve correction, and also had lesser complication rates. However, when we actually looked into the meta-analysis, they considered curves of an average magnitude of 45 degrees, which most of us spinal surgeons would not have considered for doing an APSF in the first place. So our meta-analysis mostly considered curves which were more than 70 degrees, which a larger surgical body across the world would consider APSF for. Our study did come with limitations. The evidence was moderate to low level. There were larger preoperative curves being chosen for APSF, which itself was the cause for bias. Very important factors like implant density, curve flexibility were not analyzed. The anterior release were not just performed using thoracotomies, it was also performed using thoracoscopic routes, which created bias, and there was inconsistent reporting and inconsistent result reporting between the studies, and there was a lot of heterogeneity. In conclusion, at this point, we cannot recommend if APSF is better than PSF in treatment of large curves in children, and we would recommend multi-center trials with robust methodology in order to help clinicians make this decision. And what we also understand is with this evolved posterior instrumentation, it may lessen the need for anterior release in the future. Thank you very much for your patience. We've published this meta-analysis recently in IJO, if anyone's interested in having a look.
Thank you. Any questions related? Thank you. Hi, John.
Yeah, hi. It's interesting, everything you mentioned in that study, never actually mentioned the reason why you do scoliosis correction in the first place. And it's mainly cosmetic. And it's mainly in young girls who do not like a scar across their chest. Yeah. Phil Sell did a good paper on it some years ago, didn't he, about the cosmetic impact. They don't want, if they give them the choice, these patients don't want the scar across their chest, whether it's thoracoscopic or open. And that's why I've always been against anterior, because you talk about Cobb angles, you talk about whatever, but you don't mention why you do it. And the reason is cosmetic operation, essentially.
Yeah, absolutely.
Yeah. And just to follow on with that, can you just, for our benefit, of those papers you selected, how many of those papers included in their outcomes assessment some problems?
So 3.
3, thank you. Yeah,
just
thank
3
you.
papers.
Thank you. Alex?
Well, I think John's right about the smaller curves, the curves sort of 45 to 60 degrees that are flexible. You can do all of those through posterior.
Yeah.
The question you've got to ask yourself is, why did the surgeon choose to do an anterior and a posterior combined approach? And the answer for me is, as you suggested right at the beginning of your talk, is a very severe large curve or very, very stiff curve, or in the younger patient, if you want a growth arrest procedure at the front. But in my view these days, if you're doing a growth arrest procedure to do a fusion, you're probably doing the wrong operation. You should do some kind of growing type thing. So the problem with all these studies comparing one operation to another operation is that you don't know what the patient groups are like. You can say what the Cobb angle is, but that's really only half the story, I mean less than half the story.
Yeah. Zach, forgive me. We're running a bit late, and I really do want Dr. Bunny to come and present the paper. So thank you very much indeed. Yeah. So yes, the final paper. Sorry about the mix-up in terms of the rooms, Dr. Bunny. Do you want to come up and give your talk, which is on a systemic review and meta-analysis of vertebral artery injury after cervical spine trauma. So sorry, it's a fast ball. We're going to throw in a bit of trauma there, so hence the confusion. I apologize. Dr. Sunny, please. Thank you.
Good morning, everyone. My name is Jeswin Tom Sunny, and I'm an FY2 doctor from Addenbrooke's Hospital, and today I will be presenting a systematic review and meta-analysis of vertebral artery injury after C-spine trauma. So just to give a bit of a background, vertebral artery injuries are caused due to two mechanisms, traumatic and spontaneous. Traumatic vertebral artery injuries are those injuries that are caused due to blunt or penetrating trauma, and spontaneous vertebral artery injuries are caused due to intrinsic vessel wall weakness caused due to either a vascular condition or a connective tissue disorder such as Ehlers-Danlos or Marfan syndrome. Now, the objective of this paper was to identify the incidence of vertebral artery injury and stroke post-vertebral artery injury, the mechanism of injury, imaging protocols used to diagnose vertebral artery injury, and management strategies used to mitigate stroke risk. Now, for the methods, a systematic review and meta-analysis was done in accordance with the PRISMA guidelines. We used 3 search engines, which was PubMed, Scopus, and SciNL+, to search for our papers, and we had a total of 925 papers, and after screening, we were left with 44 papers in the end. The incidence of vertebral artery injury and the incidence of stroke post-vertebral artery injury was calculated using pooled proportions random effects meta-analysis. So moving on to the results, out of the 44 papers that we had collected, it had a total patient population of 1,777, and out of the 44 papers, only 20 studies had information regarding traumatic vertebral artery injury, and it was noted that majority of the patients had blunt vertebral artery injury, and a minority of them had penetrating vertebral artery injury. Now, moving on to the incidence of vertebral artery injury, after doing a meta-analysis, it was found that the overall incidence of vertebral artery injury was found to be 0.95%, making it an uncommon phenomenon. Incidence of stroke after vertebral artery injury was found to be 8.87% of patients in 16 studies out of the 44. Now, moving on to the investigations, out of the 44 papers, only 33 studies had data on investigations used to diagnose vertebral artery injuries in patients who've suffered from trauma to the neck. And it was noted that majority of the patients had CT angiography used in order to diagnose them of the vertebral artery injury, followed by MRA and then DSA. In previous years, it was DSA that was used to diagnose vertebral artery injuries, but due to radiological advances, CTA has overtaken DSA. Moving on to the management, out of the 44 papers, 20 studies had data on management used to treat vertebral artery injuries, and majority of the patients had surgical or endovascular treatment options provided to them to treat the vertebral artery injuries, followed by a combination therapy of antiplatelet or anticoagulation therapy and conservative therapy, which came in at 3rd place. Now, this study had a couple of limitations. First one being lack of geographical data. So in this paper, we noticed that many of the papers did not have mention of the geography, and so we could not correlate the relevance of the geographical data to incidence of vertebral artery injury. Only studies that were in English was included due to language being a barrier. Iatrogenic cause of vertebral artery injury was excluded because majority of the papers did not have data on iatrogenic causes for vertebral artery injury, so we as a team excluded this from our paper. The timeline for incidence of stroke after vertebral artery injury was not mentioned in any of the papers that we had screened, and details of cervical spine fractures and dislocation that led to vertebral artery injury was also not included in this paper. However, I would like to highlight that this is the first study that included 44 papers and has a total patient population of 1,777 to quantify the vertebral artery injury incidence and stroke risk in such a large population. This can also be used to guide screening paradigms and makes it highly valuable for further research. Now, in conclusion, vertebral artery injury in C-spine trauma is an uncommon and has an incidence of 0.95%. There is an 8.87% risk of posterior circulation stroke in patients with vertebral artery injuries. And CTA is the prime method of investigation with 91.7% of the patients undergoing it. For future, further research needs to be done in order to compare the outcomes between different radiological studies and also standardize optimal management paradigms for vertebral artery injuries. Thank you.
Thank you. We're running a bit short of time, but maybe if we've got time for one question. Any questions?
I think it's higher than 1% to CTA.
John, can you come to the microphone, John?
Yeah, I think the figure of 0.95% incidence in cervical trauma is a little misleading, because I think it's much higher than that with cervical dislocations, but you didn't specify which injuries.
Yes, so we did not include cervical fractures and the specifics of that in this paper. So I think if we had included it, would be higher, as you said.
Good. So, ladies and gentlemen, thank you very much. Apologies for starting late. And now we hand over to Naveen. Is it Naveen? Is it?